Hi, I'm Dr. Steve Jordan with the Andrews Institute in Gulf Breeze, Florida. Today we're going to go over the complete elbow exam in the athlete's elbow. Like any other athletic injury, you need to be aware of the entire kinetic chain. So screen for lower body, core, and shoulder problems. They can affect the elbow. In the elbow exam, I like to start with inspection. Have the athlete put their arms out straight. Examine the carrying angle. See if they get to full extension. Notice any differences. Go to flexion. Notice any differences. And then pronation and supination. In the thrower, there can be slight differences in extension and the carrying angle, but these are not significant. If there's a big difference, you should make a note of it. I like to divide the elbow into regions: anterior, posterior, medial, and lateral. Examine them each separately. I start with the lateral. By gently flexing the elbow, you relax the extensor tendons. Start with palpation on the lateral epicondyle. See if it's tender. Come down the lateral collateral ligament. Radiocapitellar joint. Gently move it. Feel for any crepitance, grinding, or loose bodies. Feel along the lateral joint line. Inflamed synovium or plica can be a problem. Next, lateral epicondylitis. Have them resist with wrist flexion. See if there's tenderness. Put it out extension. Again, wrist extension and resist it. See if there's tenderness. That's a good exam for lateral epicondylitis. If the patient has resistant lateral epicondylitis or instability of the elbow that's vague and difficult, you should check for posterior lateral rotatory instability of the elbow. It's the only exam we need to do supine. So read, lay flat. I'll go over the pivot shift exam as described by O'Driscoll for the posterior lateral rotatory instability. Take the elbow, put it overhead, position it like a knee. This is the way I remember it. Make it look like a knee, so full supination. Start an extension, fully supinate. With your lower hand, apply valgus, upper hand, some axial load, slowly come down. The radial head should be subluxed if it's loose, and then clunk back into place as you get up into flexion. Sometimes the patient will feel this and you won't, but go slow. Axial load's important. That's the pivot shift test of the elbow. Sit up. Another condition that's not very common but you should be aware of is called radial tunnel syndrome, also on the lateral side. Usually about 3 fingers down, 5 centimeters. Palpate deep in here as the radial nerve goes through the lateral muscles. If it's entrapped, that'll be painful. The classic test for radial tunnel syndrome is resisted extension of the long finger. Don't let me push down. If that elicits pain, that's a positive test. Not that sensitive, but that's a classic test you should be aware of. After the lateral elbow, I'll go anterior. 3 things anteriorly. First is the biceps tendon. You want to evaluate that. The hook test for a normal biceps. Have the patient flex their arm to 90, fully supinate, and with your lateral index, come from the lateral side, see if you can hook the tendon. If you can hook it, the tendon's normal, but if it's painful, you should make a note of it. Lacertus syndrome is a problem in the Lacertus fibrosis. It's a post-exertional compartment type syndrome seen in throwers. I've treated over 50 cases myself. I feel over here along the Lacertus, see if that's the area of tenderness, but I also like to put them in what I call the cobra position. Examine to see if there's any demarcation of Lacertus. That's a very sensitive test for this. If they have Lacertus, that test will be positive for a line of demarcation. So the cobra position shows it the best, right in that area. One last thing in the anterior elbow is called the pronator syndrome. This is quite rare. I've actually never seen a patient with it that I'm aware of. But that's where the median nerve comes down and is entrapped in the medial muscles. They often present with complaints similar to carpal tunnel syndrome, numbness and tingling, weakness in the hand, but they all have tenderness over the pronator muscle as the median nerve divides. Anterior interosseous nerve branch won't have any sensory changes, but it too has tenderness in this area. Pronator syndrome, you should be aware of it. After the anterior elbow, we go medial. By flexing the arm up, it brings the muscles above and you can palpate the ligaments and structures better. So keep the arm flexed a little bit. Again, start with the medial epicondyle like we did laterally on the lateral epicondyle. Come down the UCL. Follow it all the way down to the sublime tubercle. If there's tenderness of medial epicondyle, again, the resisted wrist flexion test for medial epicondylitis. Resist up. See if that's tender. Do it with the arm extended. Bring your wrist up. If that's tender, you'll feel along the insertion at the medial epicondyle. From there, I like to look at the ulnar nerve. Follow it all the way through the cubital tunnel. As it emerges up here, follow it down here. Any tenderness, gentle tapping shouldn't be a problem on a normal nerve. Follow it into the FCU. Like to see if it's unstable. Put your finger on the nerve. If it's going to sublux, it will do so at near full flexion. Ulnar nerve instability. Now we've come to the crux of the thrower's examination. That's the integrity of the UCL. There have been some debate about how best to do this, but there's 3 good tests. Valgus stress, milking maneuver, and the moving valgus stress test. I'm going to show all 3. So the valgus stress test can be done in pronation, supination, and neutral. I think the debate about which is best has been put to rest by Ty Lee and his staff in their biomechanics lab in Irvine. They showed in a great study that neutral was best to show valgus laxity. That makes the classic exam position best. As Dr. Job showed us, put the arm beside your body. That holds it, controls it. You can feel the joint and the ulnar collateral ligament with your hand over here like this. By taking your arm here, you can apply valgus stress and feel it. Now you notice we're in about 30 degrees of flexion. 70 degrees, it's really hard to control humeral rotation, so that's not as good a test. Is this instability or is this rotation? So by putting it at 30, you can control that better and you don't get the rotation. So this is a better way to do it. After the valgus stress test, the modified milking maneuver. Have him put his arm up that, let me have your hand here, Reed, and support it like this. 70 degrees of flexion, 70 degrees of flexion, pull down. If this is painful, it's a positive modified milking maneuver. Then the moving valgus stress, you mimic the throwing position, come back here, go from 120 to 70 quickly with valgus stress. If that reproduces the pain, that's a positive moving valgus stress test. Dr. O'Gristle said it was about 100% sensitive, but I think it depends on how recently the player's thrown. If it's been a while since they've thrown, it might not be positive, so make a note of that. Our last area is the posterior elbow. You want to look, olecranon bursa, you want to feel, tip of the olecranon, test the triceps, push against me, Reed. If that causes pain and there's tenderness in the triceps, that could be consistent with triceps tendonitis. And then the last test is valgus extension overload. Apply valgus, gently extend the elbow, and feel on the posterior medial elbow. That's the valgus extension overload test. That completes the exam for an athlete's elbow. Hope you enjoyed it. Thank you very much.